So mine was opposite. My grandmother had amputations. She was my favorite person. She had diabetes, was not controlling it as she should have. We were poor, didn't have a lot of education on, diabetes treatments, pasta, beans, those things. All these things can end up as sugar. So her lifestyle as far as eating, it was what it was. And she ended up having amputations and the years progressed. I'm like early 20s. And then it started getting worse and she started going to the hospital, ended up getting sepsis and ultimately she passed away. So I remember being there wondering, what is going on? I knew nothing. I didn't understand. Some of the nurses weren't very friendly. They didn't explain a lot of things. And that was the worst I've ever felt. And I thought I will never be in a situation where I don't know what's going on anymore. Anything can happen to myself. If I have children, a spouse, I want to know what's going on. And I want those families to know what's going on. I want to be the one to let them know because people don't know. Yeah. There's a lot that goes on when somebody is sick and dying and you have no idea what does this mean? What is sepsis? What is that needle for? What is this drip? What is that? All of these questions and you don't know anything. It leaves you in a state of confusion and a lot of what ifs. God, if I'd have only known, So I decided I want to know and I want to help others to know. Yes. And that was another thing. It's as if, okay, well, I knew that my grandmother did not understand what was going on with her either, and she was a religious woman and she absolutely loved and trusted everybody, and she just trusted what they said. There was no questioning about it. And as that early 20s person, I'm like, we have to have more than this faith, not that I don't believe, but I needed the knowledge to go with it, and so just being in that situation. And additionally, I knew that we were different. I knew there were healthcare disparities, not as much as I know now, but I kind of figured it because I was experiencing it, but didn't quite know how to put my handle on it and say, this is really what it is, or am I paranoid? Yeah, but I remember feeling like, it seems like they would treat Susie over here a little more different than they do us because of what we are. And so that definitely played a part. And I said then I would like to go into nursing and because they need more faces that look like me so that we can actually have trusting relationships. Yeah. I remember having a patient one time. I was on a nursing floor and I was a progressive coronary unit. And I remember coming in and they said, well, we've got this patient who is very, very defiant. She's 90 years old. She's stuck in her ways. She doesn't want to do anything. She doesn't want to take her meds. She doesn't listen. And I thought, okay, well, these are the meds I got to give her today. I'll talk to her. Well, she probably won't take them because she just has an attitude. She's old. That's how she is. I walk into the room. I said, hi, Mrs. Such and Such. I'm Deanna. And she looked at me and she said, I am so glad to see you. And I said, you are? You've been looking for me? And I said, I've been at home taking care of my children, and now I get to show up and see you. And she said, honey, I'm so glad to see you. Do you have my meds? I said, I do. I do have your meds, And we're talking. I gave her meds. And then I came back out, and they were like, you gave her meds? She took them? I was like, she's very pleasant. I said, why didn't she take them with all these other shifts? I said, because you guys don't look like me. She is 90. She doesn't trust you guys. And that's what I'm saying. She needed to see someone like me. You guys were thinking she was defiant. She didn't want to comply with anything. And the whole time she wasn't comfortable with anybody outside of her race. So, and giving them that lesson, they were like, oh, okay, I didn't realize it was the other way around sometimes. Yeah. Yeah. We can feel like we want people like us so that we can trust them. So I did not. I was a late nurse. So when this happened with my grandmother, I was only about 21, 22 years old. And then I was working at a factory and I thought, okay, when I graduated, I was supposed to be a journalist. And then I realized, well, maybe I should just stay here. I think I was kind of scared to branch out. So I stayed and I was working at a furniture factory. And that's when my grandmother, she got sicker. And then I was still at the factory and I realized I need to be a nurse. I've got to be in there, got to be in those rooms. I've got to know what's going on. And there are people who need me there. You know, they need me to explain it to them. They need to trust me and the information coming from me, specifically those who look like me. So, about a few years later, it took me a little while, I decided I'm going to go to nursing school. So I started taking classes at the community college, and then I transferred to another university. And then I ended up graduating with my bachelor's degree, but I think it was around age of 29. Yeah.
That's amazing.
And then I ended up getting my master's maybe 10 years later, and then my doctorate. So, yeah. So right now I'm an associate director of behavioral health clinical operations, and it's two departments. It's a utilization management department and a case management department. And this is a remote position, and all my staff, they work from all over the country. Yeah. And so the utilization management part, they process authorizations for patient stays, behavioral health from various facilities and various levels of care. Could be outpatient, it could be partial hospitalization. We mostly work with inpatient and residential treatment. And this is from adolescents to older adults. And so they have to fit the criteria to be medically necessary for them to stay in those particular facilities or levels of care. And so when they meet, majority of the time they do meet, for various mental illnesses or issues that they're going through. And so while they're there, we have the case management side preparing for their departure so that whenever they get out, they'll follow up and make sure they're going to see their doctors or they're going to see their psychiatrist. They're making sure they got their medications. They're utilizing primary care versus the urgent care and the ER, and just kind of making sure they have all the resources they need as well to prevent the readmission, to going back inpatient. And so they kind of work hand in hand. One takes care of one side, the other one takes care of the other. I oversee the daily operations of this, making sure the statements of work are exactly, we're following those, the standard operating procedures, making sure those are being followed and updated, the quick reference guides and all those things, ensuring that the things that we're, the facilities that we are authorizing, they are in participating with the provider and with the insurance and in network and all of those things. So we have HEDIS measures as well. And one of those HEDIS measures is that once a patient discharges from a facility or a level of care, that once they get out, they have 7 days to see a provider. So we have to ensure that they have their appointments. We can't physically make them go, but if we follow up with them within 7 days, make sure that their appointment is scheduled and that they're going to attend that appointment. So we do have those types of measures to make sure that we're meeting that criteria that will help to have the positive incomes for those members. I feel like I am. See, it's you. This part looks more business oriented, and then you bring in the clinical aspect, which is greatly needed, And to be honest, I'm a little biased here, but all the people that are involved in these organizations, if they're not clinical, they're making numbers decisions. It's not quality of care. It's all the numbers game. It's okay. We've got these people. We've got to figure this out, but there's no quality involved. That's when that nurse needs to come in and have that voice. We need quality. The data is one thing, of course, and we can support that data more if we get the quality involved. You have to put it in there. So to show what that data should be, the numbers can be whatever they want them to be, but if you want the numbers to perform as they should, you need a clinical person in there to support. This is why the numbers should be this instead of what you guys stated. Mm-hmm. Yeah. At first, when I would see the data, I would be taken aback, and it's like, well, everybody should be doing this many reviews, or you should be enrolling this many people, and this should be happening. And I had to say, hey, if we're doing those numbers, there's no quality. We're calling these people. We're not following up to make sure they're good. We're not having those meaningful conversations. We're basically calling, hey, are you alive? You're breathing. You got a pulse? Bye. It's checking the boxes. If you want checking boxes, that's fine. But it's going to be the same. Everything is going to be higher readmissions. Those numbers are going to go up. All the HEDIS measures are not going to be met because we can't follow up within 7 days properly, probably skipping that question, safety questions, those types of things. If you want the quality care involved, we have to adjust the data to fit it. So I have to be the voice in the room to state those things. Yeah, especially in the behavioral health realm. I ended up working for an outpatient facility, and I was the psych nurse there, and I had the sickest of the sick. I mean, they're upright, they're walking, they're not impatient, but they're just a step away from it, you know? I would be in a locked room with them, and I would give them their Haldol or Risperdal injections every 2 weeks, every 3 weeks, just depending. They would come to me with all kinds of symptoms, especially if they had been drinking or doing drugs, which exacerbates all the paranoia, you know? I had a patient who came in because he was seeing Pac-Man ghosts. And he was like, it's the Pac-Man ghost. There's one right there. There's another one. And I was like, okay, have a seat, you know? And then he was like, I'm really glad you're here to help me. And they like really relied on me. And I lived in the same town that I practiced. So I'd see them outside. I'd see those same people. I'd go to Walmart and they were like, hey, I don't see those people no more. Them ghosts, they're gone, you know? And everybody's like, what's going on here? I was like, okay, I'll see you in my office, you know? But it was the fact that they really relied on me. And I really liked watching these people come in all confused, discombobulated, give them their medication, help them to feel healthy and continue it, and then watching them go forward from there and feel so much better. Yeah. It's nothing like seeing somebody's mind completely wrecked where they almost don't want to be here. And you talk them, okay, off that ledge and give them that medication to make those chemicals stable. And they're like, oh, thank you. I was in there. I was also voluntarily admitted myself as the nurse. I'm the psych nurse, right? But I've got a life outside of this job. And I am going through the worst time of my life. I'm in a fetal position. I don't know if I want to be here. It was a lot going on to the point of giving my children to my mom, to trying to get on my own and starting all over. My heart was broken. My whole house was in turmoil. My relationship was over. I got hit in the back of the head for it. You know, it was just like, what is going on here? And I ended up going into the psych ward, and I saw my patient there. And I was like, oh, how convenient is this? And he was like, what are you doing here? I said, I told you, don't let those degrees on that wall fool you. We are not different. We are not different. I just manage a little differently, and you're going to do it too. And I'll see you when I get out of here. We'll talk some more, you know? And so that was something, to be the patient and the nurse at the same time. It's a thin line. There's a thin line. Yes. Yeah, I want there to be more people who are advocates of those who need it, you know, because that was my purpose of going. I mean, in addition to wanting to know the information and not wanting to be in the dark and needing to know what's going on, I needed to be an advocate for those that look like me, for those who don't understand, for those who will nod and say, okay, and trust you and really don't get it, you know? And so I like meeting people where they are so they know exactly what's going on, being truthful. If someone's going to die, I'm not sugarcoating that. You know, I'm going to let you know that it's happening. It is happening, you know, and you're going to have to prep for it. Whew. I cried. Oh my gosh. My first code was in an ICU, and this was a big hospital, really big hospital. They had like 3 ICUs. And this patient looked like me, looked like my grandmother, you know, and she was really sweet. And she was on the phone talking to her family. And she's like, well, I'm about to eat my breakfast. So I'll see y'all when y'all get here, and then she hung up the phone. And I was like, okay, I'll be back to check on you a little bit later. I know your family's coming. So do you want your bath before or after? She was like, no, I'm just going to eat my breakfast. And then later on, I said, sure. So I go out, I go around the corner and I go down the hall a little bit more. And it's code blue. And they said the room. And I'm like, that's my room. Oh my gosh, run back in there. And this is a teaching hospital. So all the nursing students know to run in there. So nursing students are like going at it, CPR, going at it. I'm doing the same thing. Like I'm jumping in there with my compressions. And when I'm looking at her eyes. I'm also looking at the monitor. I'm looking at the doctor. I can feel all the energies in the room. I'm looking at her and we stop and her eyes are opening. I was like, she's got a rhythm. And then it codes again. It's like, nope, keep going, keep going, keep going, keep going. And then like, everybody's like, okay, maybe we should call it. I'm like, no, I would not give up. I'm going and I'm going and I'm going. I was like, okay, all right. Looks like she's coming around. Then she'd do it again. It happened so many times. And the doctor finally was like, okay, we're calling it. And I just felt all the blood just drain from me.
That was your first?
That was my first. And I was like, it was a lot. I almost said, I'm not doing this. I went outside. I called my mom. I was in tears. I said, I don't want to do this anymore. I don't want to do this. This woman was fine and she died, and now her family is about to walk in there and they have no idea she's not here anymore, So I go there and you can hear the family screaming, I'm just going to be honest with Black people. We're a little extra when it comes to our feelings and our people, and we go extra, and it was a lot. It was a lot because whenever they left, she was fine, whenever they got off the phone with her. So that was my first code. Mm-hmm.
And all the air.
Mm-hmm. Yes, I felt.
Did you feel like,
I was mad at the monitor. I was mad at everything. There were no signs. There were no signs that this woman was about to code. Those are the ones that are the hardest, the ones that you were not expecting. The one, they're here and they're in the clear now. They're doing great. I actually had somebody. It wasn't my patient, but it was my teammate's patient, and the son had gone to get the car because he's being discharged. His dad is sitting in there. He comes back and he hears code blue. It was his dad who was dressed, ready to go. And everybody was doing CPR. Everybody's in there. He didn't make it. He was being discharged. Yeah.
Did you work the next day?
Yes, I did work the next day.
How were people supportive?
Everybody was talking about it. Like, wow. I mean,
to call rapid.
No. These situations they were fine, and then they just weren't. Yeah. They just stopped. There was no labor breathing. No one was sweating. There was nothing. Everything was like, okay, everything's good. We'll be back. Then they're gone. Yes, that they've had similar experiences, and then they had gotten used to talking to these patients. It was like, he was very sweet, and we talked about this, and then his son, and all those things, and my grandson, and you bond with them and the families, especially if you've seen them for a while. It's a lot. Yes, it does. It's still, at first it's that, oh my gosh, why did this happen? All the what ifs. I should have. Why didn't we? Did we miss something? Tracing your steps. But there's nothing. There's nothing. But knowing that you provided comfort to the family, it helps.
Right?
No, I'm the strongest.
Worst thing that
I'm the strongest in the camera.
Yeah.
I'm the strongest when the lights are on. I'm the strongest on the stage. Backstage, I'm a wreck. Yeah. Exactly. It happened for a second, but I had to take a deep breath, and I knew that family is coming. I've got to be there for this family. We got to go. This is backstage talk. We got to go up front for the cameras now. All right, wipe the tears. Let's go. It was very difficult. And they're going, we just talked to her, as you have to just let them grieve, and just be right there. Sometimes they'll hug you. I hug them back, you know. I never say I understand or those things, I'm